Hi everyone, my name is Laura Talamo. I'm currently a Hematology Oncology Fellow at the University of Virginia in Charlottesville. We are here today at ASH 2016 and I've been asked to talk about my project called Safety of Direct Oral Anticoagulants in Patients of Extreme Weight. So thank you very much for asking me to come along and present this topic. So to introduce the topic, direct oral anticoagulants, or DOACs, have been approved for the treatment of venous thromboembolism, prophylaxis after hip and knee surgery, and stroke prevention in non-valvular AFib. The DOACs include the direct thrombin inhibitor, tipigatran, and the anti-10A agents apixaban, edoxaban, and rivaroxaban. So at our institution, we prefer to prescribe the DOACs when we are able. Versus warfarin, they're much easier to administer. They have fixed dosing requirements, so you don't need to get your laboratory values checked, and there's fewer drug-drug interactions. However, there's no specific dosing recommendations for DOACs in patients of extreme body weight. And the reason for this is because in the large trials looking at the anti-10A agents, the obese population was a small number of the patients that were included. There were inconsistent weight cutoffs in these trials. Some used 100 kilograms as considered as obese, some used 120 kilograms. And then the pharmacokinetic and dynamic studies are really lacking in the obese population. So for this reason, out of concern that the obese patients were possibly underdosed, the International Society on Thrombosis and Hemostasis in June of this year put out guidelines that suggested avoiding DOAC use in patients of a certain weight, 120 kilograms or a BMI of 40, unless specific drug levels were obtained. However, at the University of Virginia, we used to prescribe DOACs for all of these patients at the fixed doses that are recommended prior to release of these guidelines. So as an institution, we wanted to review the safety and efficacy of DOACs in these patients. So we performed a retrospective analysis of a random sample of patients that were given DOACs for any of the indications I previously discussed over this 5-year period. We looked at 3 groups, and you can see the weight cutoffs in the individual groups. We reviewed 113 charts from a much larger population of charts, and 34 charts were excluded because we didn't have the data for the chart review. You can see baseline characteristics were obtained with the following laboratory values: creatinine, hemoglobin, platelets, and INR. And the outcomes that we wanted to assess were bleeding, including major bleeding, which was defined as acute clinically overt bleeding requiring ED visit or admission, and clot progression. So this is a table of our patient demographics. You can see that we had a fairly even number of patients in each of the groups. They're as well distributed. You can see the average weight for each of the patient groups. The ages were pretty consistent throughout the groups, but we did have a difference in the male to female ratio, with a small proportion of patients in the underweight group being male and the majority of the patients in the overweight group being male. 60% of the patients did receive apixaban versus 40% receiving rivaroxaban. This was before we were prescribing edoxaban, and tipigatran was not prescribed for these patients. So this is a figure of our bleeding rates that we had noticed. You can see that in the underweight group, which is the orange bar, and the overweight group, which is the blue bar, that they were fairly even or equal number rates of bleeding in both of the groups. To the left, you can see that major bleeding occurred in about 15% of our underweight patients, and then overall bleeding was over 30% in both groups. Major bleeding, for the most part, was GI bleeding, and the all bleeding included minor things such as epistaxis. So what was surprising to us was that both the under and overweight groups were bleeding at pretty equal rates. And then this table just shows you the absolute numbers of the patients that were bleeding and the rates of clot progression. Surprising to us was that there was so few clot progression, especially in the obese group, which had 0 patients that presented with clot progression. This is a retrospective review, of course, so it is clinical clot progression, so patients that presented with something that would trigger the clinician to order a Doppler ultrasound, such as leg swelling, pain, or erythema. So you can see that overall the absolute number of clot progression was fairly low in all groups. So just to summarize the highlights of our study, almost 30% of all the patients did have a bleeding episode. The majority was not major bleeding. Bleeding was high in both of our low and overweight groups, which was surprising. No major bleeding in patients of normal weight, though there were 4 and 3 in the underweight and overweight groups respectively. 2 patients had clot progression versus 4 in the normal weight group, and no patients in the overweight group. Again, was surprising. The one thing that we did not include in table format was that there was no significant difference between patients who bled and those who did not bleed in terms of the laboratory values that we had talked about previously. So in conclusion, we did find a statistically significant proportion of underweight patients that had a higher rate of major bleeding. The low weight and underweight patients that have similar rates of bleeding, and this was surprising to us, and we were really interested in figuring out why this is happening. So this is leading us to try to develop a prospective trial, which I'll talk about in a minute. Wanted to point out that patients received the same dose of DOAC, so we didn't think that the difference in the bleeding and clotting was related to the different prescribing patterns. And then because these guidelines, the ISTH guidelines, were developed out of concern that overweight patients were being underdosed, and we did not see that in our group of patients, that led to the next slide, which is that we want to formulate a prospective study to begin to figure out why that's happening. So questions that we are interested in finding out are we overdosing DOACs for these underweight patients since they were bleeding just as much as the overweight patients? Why are they bleeding at the same rates? If we are concerned that the DOACs are being overdosed for underweight patients, does that still hold true for overweight patients? Probably not. And is the fear of clot progression in overweight patients legitimate since we had 0 obese patients with clot progression? So what we would like to do is formulate a prospective study, getting drug levels and assessing clinical outcomes in both low and overweight groups of patients to understand in the groups of patients that are bleeding, what are their levels, and in the groups that are clotting, again, what are their levels. So I would like to thank you all for watching. I would like to thank my fellow collaborators. Serbi and Donna are 2 pharmacists at the University of Virginia that have an interest in benign hematology, and my research mentor, Dr. Hilary Maitland. So thank you so much for watching.